All right, so we're going to start our session about workforce. I'd like to welcome back Janet Baseman. She's been introduced several times. I'll just call her Janet Baseman this time. Michelle Campbell is the director of the Center for Data Modernization and Informatics at the Washington Department of Health. Michelle and her team collaborate with federal, state, local, tribal, and private partners to guide agency strategy for the modernization of critical public health infrastructure. And later we'll have Ann Zink join for another perspective on workforce. Ann Zink is the Chief Medical Officer for the Alaska Department of Health and Social Services Division of Public Health. Her priorities as CMO include building stronger partnerships between DHSS and Alaska's healthcare providers and providing support statewide for locally relevant ways to help establish healthier communities across Alaska. So, thank you.
Thank you, everyone. We decided to sit this morning and have our screen here so we weren't turning around and looking away from you the whole time. So we'll go ahead and get started. So the topic we're going to be covering this morning is the partnership work that the Washington Department of Health and the University of Washington have been doing really since the beginning of data modernization, with doing an in-depth assessment and gap analysis of our data modernization needs, as well as helping us develop our workforce plans, and then some work we've been doing on a pilot workforce development program using a series of webinars, as well as developing a public health data learning center. All right, so this effort has been, of course, informed by the CDC's Data Modernization Initiative, which you have all been hearing quite a bit about over the last couple of days, as well as work that the Washington Department of Health had been doing prior to COVID and data modernization called the Data at Health Initiative, which we're going to be relaunching again this fall across the Department of Health and with our local partners. So back in the fall of 2021, like our other states, we completed our first Public Health Data Modernization Initiative assessment. We partnered with about 20 subject matter experts from across the agency from a variety of areas, epidemiology, laboratory, immunizations, IT, and a variety of others. And the goal of this assessment was to really understand what our current capabilities and capacities were, as well as the areas of opportunity to really inform our future modernization plan. So after submitting that plan, we got some additional questions and requests for feedback and from CDC. And at that point, we decided if we were going to really dig into this assessment, we wanted to gather as much information as we could to really inform our efforts moving forward. So at that point, we reached out to Janet and her team and asked her to help us really do a deep dive, not just with our Department of Health staff, but also with our locals.
Let me just start by saying we were very excited to get that call because the University of Washington is very excited about partnering around workforce development. As I'm sure you can imagine, all of the schools of public health are very keen to be modernizing along with the public health system so we can ensure a competent workforce moving forward. So let me just start by saying, you keep hearing my colleagues say partnered with Janet. I just want to make it clear that there are like multiple different teams, even outside of my own department, that are doing this work. We in fact have a center called the Northwest Center for Public Health Practice, which is housed in the Department of Health Systems and Population Health, that actually does workforce development and public health evaluation across all of Region 10, so the Pacific Northwest states. And that center has been in existence since 1990. So they're really good at workforce development. They're really good at developing training. So this call to Janet went to them, although I was involved. So we were super excited to help expand and thought it was really visionary to get this call from Michelle and the team because we thought, like we took a look at the instrument that they had submitted to CDC and thought, there are some voices missing here. So the first thing that the UW team did was that we conducted interviews with 18 of the 20 original staff who had completed the initial CDC assessment. And then we added some additional Department of Health staff to that survey. We had subject matter experts across surveillance, IT, health statistics, epidemiology, lab medicine, governance and data science. And then we also expanded our assessment to be a little bit more comprehensive by including local public health jurisdictions across Washington, but including larger and smaller public health jurisdictions with geographic representation across the state of Washington to get their voices included into data modernization efforts in order to inform the future DMI work that Michelle and her team were leading. So we added to the assessment 38 staff across 13 different local public health jurisdictions across Washington in our interviews. So we then conducted a gap analysis, and if you're familiar with gap analyses, what we did was pretty straightforward. Our goal was to understand the current state of public health surveillance infrastructure, to capture insights through our assessment activities and recommendations from users in order to define a desired end state. And we then conducted the gap analysis in order to identify the differences between the current state and the desired end state, and then developed a set of recommendations to submit back to Michelle and her team to close those identified gaps and to prioritize the next steps. The only thing I'll add to this real fast is that the Department of Health had also contracted with McKinsey in order to do a review of State Department of Health's internal needs to move toward DMI. And the University of Washington team took our own gap analysis and crosswalked it with McKinsey's findings in order to generate a kind of consensus set of recommendations. All right, so I could spend a really long time talking about the overall findings, but this is a pretty short session. I think some of these will not be a surprise to those of you who work in public health. We've talked about some of these already. Improved interoperability and breakdown of unnecessary data silos, we've already talked quite a bit about. The second finding here, reduce burden on end users to move data into action. I'd like to just provide an example for a couple of these that may be a little less clear. So reduce burden on end users. An example from our interviews included pre-made queries for local public health agencies that were created by the State Department of Health, were serving a useful function, but the LHJ respondents were saying that those queries were not always accompanied by sufficient information about the data, so data dictionaries or other documentation that could make those tools more useful. So the third bullet here is adequate staffing, training, and workforce support to tackle burnout. I think that one speaks for itself to all of the public health folks in the room. Meaningful engagement between the state health department and the LHJs. An example of this was a response that we got several times from our LHJs indicating that their data staff wanted to be a part of the decision-making around processes for new data systems, around objectives for data modernization. For example, a lot of our smaller local public health agencies in Washington felt unheard in decision-making processes related to a specific surveillance system that everybody was expected to use. And then finally, to prioritize communication, change management, and governance. And I think this one also speaks for itself.
So we got a very detailed and helpful report from the Northwest Center. And some of the recommendations that made around workforce was one, of course, to have a comprehensive plan to really build the infrastructure to support workforce development within the Department of Health and the state. We really need someone that is going to lead these efforts. This isn't something that just happens on its own. It needs to be intentional, and we need to have someone really leading that strategy, but also really the engagement and making sure that as we move this work forward, we're on the right path. So one of the topics that came up very regularly in the interviews was data science. So that was a consistent training request that we had, so we knew that was going to be a part of what we did moving forward. So then we needed to prioritize what we already had and fill what we knew were some really obvious gaps. So we also wanted to make sure that as we were doing these things, communication was a strong part of that. We could be doing a lot of really good work, but if we aren't properly communicating it and engaging it with our target audience, then it was just not going to get used. So the training plan was informed by some of these competencies and frameworks that you see here. The Northwest Center is very skilled in this type of training development, and we're the perfect partner to help us drive this work forward. And it made so much more sense to work with them than to try and recreate that expertise internally. So we got this report and we knew that we were going to need to do some work, but there were so many things that we could do. And so we kind of said, all right, well, what do we start with? How do we get this moving? And so we decided to take two different approaches. One, we started a 3-part webinar series that was shared with DOH and LHJ staff. The first one, we decided data science was a really big topic that people were interested in, but did we have common understanding of what data science was? How does it align with the tools that we're already familiar with epidemiology and informatics? How could it be applied in public health and expand the toolkit that our staff has? We then did 2 additional webinars that showcased work that public health staff at the Department of Health and at the local health jurisdictions had been doing over the last couple of years to really implement data science into their work. And then the next piece we decided to do is we really wanted to make it easy for people to find these resources. So the Northwest Center did some really great work curating and evaluating existing trainings in these areas that we could bring together in one place so that people were not regularly having to go and try and figure out where quality training existed.
Yeah, so I'll make a quick comment on the data science 3-part training, which you can see here we referred to as a pilot because you would think that it would be very straightforward how to do data science training series for public health, but as Michelle was pointing out, kind of even understanding what the common expectation of data science for public health was still very much in process. So for our first session, we actually, somewhat controversially among the team, recruited somebody who was not a public health person, but who was an expert in data science, who was a teacher, and he had done a ton of e-learning at the UW and at Harvard Extension on data science. And we met with him, and he knew so much about data science applications in other industries. And we thought, oh, this is a great intro, like a non-public health person that can come in and talk to us about the fact that our problems are not so different from other industries who have grappled with similar problems, even if we are a little bit behind. And then after that first session, we pivoted toward public health in Washington, having one case study where data science was used at the state level, and then a second case study where data science was applied in Washington State at the local level. Okay, and this is the list of, so as Michelle mentioned, we had our data science pilot training, and then we also had our curated training resources, which we were making available on a website that I'll show you in just a second. But the team, the cross-agency team between Department of Health and my team in the Northwest Center for Public Health Practice had to prioritize. So if you work in public health and you've ever seen like PH Train or kind of like the trainings, okay, thank you for the smiles, Chris. It's like very overwhelming because it's just like a giant repository of like so much information, and it's really like unclear whether it's great or outdated or all of those kinds of things. So we didn't want to recreate that. we wanted to take some targeted areas, and these are the areas here on the screen that we were focused in, and then we only wanted to pick a handful of trainings that we felt were current and relevant, and so we actually had my students who were hired on the project going through and taking these trainings, characterizing them for us so that we could make good selections for our curated training set, which we put onto a new kind of with its own branding website that we were calling the Public Health Data Learning Center, and it also has our recordings of our data science sessions in addition to the curated trainings that we created together.
And I realized that we did not put the link for this site in the slides. So it's, oops. I know, we were slacking. So maybe you can make us one. So it's phdataLearn.uw.edu, and we can make that available afterwards as well. All right. So what's next? We've done our initial webinar series. The site has been live for about 5 months now. So before we did a lot more development or work in this area, we wanted to go back and say, is this working? Is this what you actually want and need? So the team at the Northwest Center is going back and doing some additional interviews with staff that they talked to before, people that are using the site, to see if we're on the right track or there are things that we're missing, to kind of inform our next steps. While that is going on, we want to continue to offer webinars. So we want that to be kind of a mix of industry experts, but also really want to engage the people doing this work in the state to share the work that they're doing, because there's so much that we can learn from each other and not just from national resources. So we are looking at what categories would be good additions to the site. A couple of things that are coming up pretty frequently are storytelling with data, as well as data governance. So those are areas that we're going to be looking into. And then lastly, we've been talking with other states, several which are in this room, that are interested in joining our efforts and really not recreating this work in every single state, but how can we come together and really support the needs of the region. So we're looking forward to the possibilities there of how we could really come together and make this something that can benefit public health in the Northwest.
Great, thank you. And that's it for the formal presentation. So let's invite Anne to join us to kind of share some thoughts on the national perspective.
Great, thanks. It's great to be here with all of you all, and thanks, Janet, for being here and including, as I mentioned yesterday, for those who are here, I'm Dr. Ann Zink. I'm the Chief Medical Officer in the state of Alaska, but I'm also the ASTO President, so the Association for State and Territorial Health Officers. And currently, like if you look at the de Beaumont Foundation information, we've seen 46% of the public health workforce leave in the last 5 years, and that's married with about a 20% leave in the healthcare sector. So we're really seeing across multiple factors just a real loss of people in this field, while there's this huge demand for data and data modernization and for transforming systems. I'm presenting at Civitas coming up later this week, and there's all of this concern in the public about data and data security and data sharing, and they really don't believe that our teams are working with faxes and that the clinicians don't have any of that information that you just collected. And I think there's this huge gap between the public's understanding of data and data modernization and where we're at with the reality of where it's at on the ground. And I remember so many times during the pandemic where, our brilliant epidemiologists were like, I am just a data entry person. All I am doing is I'm literally taking this one data set and I'm entering it into different systems. And in fact, we ended up getting National Guard to sit in our lab to literally enter one data element into 3 different data systems so that we could be able to get it to the different cards. And so when we're using National Guard to enter data systems, one, that's morally heartbreaking as, epidemiologists and as clinicians. And I love the perspective that, burnout is not a failure of the person, burnout is a failure of the system. And so what ways can we think about improving the system so that we're not burning out our public health workforce? And I think things like this, to being able to do training I would just highlight the kind of the Pacific Northwest collaboration on this space. There's some really great CSTE fellows in the room, and I guess we just wanted to pause and have them stand up so we could clap and appreciate them and their work. So all the CSTE fellows. They're the ones who are sitting into this space and learning. And I'm very fortunate to have one in Alaska who was trained by Janet and mentored by Bryant. So I think we're all in this connection together in trying to figure out the workforce. And so really exciting to see the space that's here. I guess I would also just really invite our industry partners to think about what way that they could really play a role with this. I really think about the US Digital Services, and when we really struggled as a nation to be able to have good technology to move forward, US Digital Services was created to be able to bring people in the technology field into the government space to learn in that space and to be able to come back. And I've always struggled with why don't we have that at a state level in the same sort of way, so that people in industry can learn what it's like to be in public health and what are barriers and limitations. I was just at a policy conversation in Boston yesterday, and I get yelled at by VPs of executive companies on a regular basis, and they say, your procurement takes so long, you're killing my company. And I'm like, well, it's not actually my procurement process, but I would love to own it in so many ways for so many different reasons. And I also own my HR department. But there are these limitations, and part of that is because we're using state dollars and we're using federal dollars, and there's a lot of good reasons for having this double check. So come work with us and learn about the barriers and obstacles that we face within state and local government, and then you will be able to tailor your industry tools in a very, very different way. Because we are not the private sector. We don't have the same tools in operation. We cannot buy you lunch for any reason, even if it's like a cup of coffee. And so we have to work with those spaces. And if you understand our world, you'll be able to engage in our world much better. So I really think that there's an economic benefit for private industry to think about being able to have people work within our system for a couple years and then go back. And I think that will help us to understand it on the same. I would also argue the same thing for healthcare. The healthcare space and the public health space, it was great to see the presentation earlier with the smart card and thinking about that. And all I can think about is all the patients I see who I don't have any of this information on and how to move forward. But then I also think about like the hemoglobin A1Cs that all of our data, or all of our healthcare data systems have, but none of my public health team can see. And so my public health team is making these gigantic decisions about chronic disease and chronic disease prevention, but they can't even see like one of the major metrics that we could easily use. And that's not a technology issue, that's a policy issue, that's a data agreement issue. But when I meet with large EMR vendors and they have no idea that I couldn't see that information, it's hard for them to change their systems if they don't even know what we can and can't see. So I'd really encourage our private partners to consider partnering with us as we think through this workforce challenge, because I think it will benefit us all. So I appreciate the conversation, and turn it back over to Bryant. Or someone? No?
Are we taking questions for
Questions?
this, Joe?
I'll turn it over to you. I'm just almost not turning to you.
Did I want to, oh, I love acknowledging my other students. David, are you here? Stand up, my friend. Where is my postdoc, Adam? Adam, stand up, my friend. Is Andrea here? Andrea, stand up. Stand up. Thank you, Andrea. And did Ann Massey make it today? Ann, stand up, girl. Hi. These students are doing this work, all of it, that I've been up here talking about, from DMI to the Student Outbreak Response Team. By the way, all of them are either current or former members of that team, to the WA Notify work, I already shouted out to Adam, and then other projects that you haven't heard about, including providing capacity support to rural public health agencies in Washington State and trying to figure out how to help them with their efforts to kind of modernize and regionalize their efforts. So thank you for that. You guys are amazing.
Let's give them a big round of applause.
And like, speaking of workforce, like you are, I was gonna sing Whitney Houston for a minute, but I'm not going to do that. You all know the song. They're the future, and we need for them to understand these challenges, just like you're talking about. Our industry partners need to understand. Our future workforce really needs to understand. Mm-hmm. And we need to be, with a tone of humility, I'll just say, the schools of public health need to modernize along with you all so that we can ensure alignment between the skills and the needs of the agencies.
Yeah, I couldn't agree more, and I think that that academic partnership, the state and local partnership, the industry partnership, there's one other partner that I mean, we talk a lot about communities and the need to get communities in this space. For us in Alaska, tribal and tribal data sharing and their expertise, really want to highlight. I just also want to give a shout out to the CDC Foundation, not only for kind of organizing this, but I think during the pandemic, the most common question I got was, I need workforce. I need workforce to do this. And I'm like, I actually don't have a warehouse of nurses that I can just open up and deploy to you. I would love to, but I'm not sure they would love that in multiple reasons. And honestly, the CDC Foundation became that warehouse. And so I think that they were able to braid funds together and be able to overcome many of our HR challenges that we couldn't get through quickly at a state level. And so we could say, we need this workforce right now for this, this, and this. We jointly hired with the CDC Foundation and the state, and within 2 weeks we would have someone on. Different states had different experiences from that. Most states had said it was a game changer and made a big difference. Some states, their staff left because they were paid higher at the CDC Foundation, so there was like a little bit of bitterness there. So I think we have to just consider kind of like what that space looks like, but ultimately, it's great to have public health people get paid, so that is exciting. But I would say in most states, the most common set of needs was on data. And how do you have data to support the states and data? So it was a lot of administrative work that needed and the data, and they were able to just bring on really large groups of workforces, and we were able to get more diversity in our workforce in the data space because we were able to hire from people who were out of state or needed to relocate to be with family or having telework agreements that our states wouldn't allow at that time. So there were flexibilities within the CDC Foundation's hiring that state and local jurisdictions could not overcome that allowed us to really be able to get a skill set and a diversity of workforce that we were unable to do. And so I just want to highlight, I think that was a huge success through the pandemic, and I think we need to figure out how to replicate that more for workforce moving forward.
That's a great point.
With Amazon Web Services. So you may see some of these little cards on your table. We have started, since you all were doing a call out for industry to help, we have started creating a set of public health pathways for learning about what is the cloud and how do you use it. So the pathways that are in the blog that are talked about in here are talking about AI services that we found are very useful for public health specifically, and other ways to really orient public health to the value and the possibilities within the cloud. We've also created some immersion days where people can come in and do hands-on keyboard kind of work to learn about it with specific public health use cases. So I think that I completely agree, you need to make it relevant to public health, because we've had public health folks go to some of our standard trainings and they're like, this is not me, I don't see myself in it, and it's really hard when you're learning about a new area completely to see yourself in that future if you don't even understand what you're learning. So completely agree with everything you all have said. At least we're trying to help with the industry perspective. But we'd also love to get feedback on these trainings because it was just my first pass, and we can always improve. So thanks, folks.
Awesome. Thank you for doing that.